Mo, can you make me a host?
Absolutely.
So I can share my screen?
You're a co-host now.
Okay. So let's start. Everybody can see that. So we're talking today about heroin assisted treatment or injectable opioid agonist treatment in Canada. In particular, we have 3 clinics now in Vancouver that are prescribing diacetylmorphine and prescription heroin. So we're happy to have everybody here to learn about what we're doing in Vancouver with prescription heroin. I want to acknowledge that we are gathering, and I'm talking from the traditional territories of the Coast Salish people, including the Musqueam, Squamish, and Tsleil-Waututh nations. And none of us have any conflicts to report. Let me just acknowledge as well the clinic participants here at Crosstown, the patients here at Crosstown who attend regularly, participate in research, and are just so important. And we appreciate the commitment they have to our ongoing learning. And I also want to acknowledge Eugenia Yevedi-Yokas, who's a professor in the School of Population and Public Health, was the PEI on our NAOMI and SALOME studies, and continues to run our trials and lead our research at the clinic. She assisted with many of the slides here. Okay, and of course the frontline workers. It takes a team. So just by way of background, opioid use disorder is a chronic relapsing illness, and we have several effective treatments in methadone, buprenorphine, sustained release opioid medications, but they don't work for everybody and they don't work all the time. And there is growing and substantial evidence from Canada and European studies showing that medically prescribed injectable diacetylmorphine and hydromorphone are effective, feasible, and safe treatments. And WHO guidelines include no single treatment is effective for all individuals. We need this diverse treatment options. And in the future, we're going to need even more options, of course. So our story starts here in Canada with NAOMI, which was the North American Opioid Medication Initiative. That trial asked the question, is prescription heroin superior to methadone in that population that continues to inject street opioids, illicit opioids, despite attempts at the standard treatments, methadone? Ran with a site here in Vancouver, this clinic, and Montreal from 2005 to 2008. We were able to show that yes, it is superior, published in the New England Journal of Medicine in 2009. Unfortunately, we weren't able to transition to a program at that time. There were just too many regulatory barriers, too much stigma. Since then, there's been a Cochrane review published, which shows that prescribing diacetylmorphine has benefit over continuing standard oral treatments. Over 8 randomized controlled trials involving over 2,000 patients now. Adverse events were consistently more frequent than the heroin groups, but these are safe drugs in the supervised model. We also published cost effectiveness data in the Canadian Medical Association Journal. Diacetylmorphine is not only more effective than the standard oral treatments in this population, is also more cost effective. And when you have that situation, it's called dominates. Injectable treatments dominate standard oral treatments in this population. If you have better care at less costs, that's a program that should be expanded. So leaving NAOMI, we weren't able to expand to a program. We weren't able to get access to prescription heroin. The injection clinic here in Vancouver and in Montreal closed. But we managed to keep the infrastructure here at this clinic. And 25 of the participants in NAOMI who were receiving injectable were actually receiving hydromorphone. The blinding wasn't broken. And in NAOMI, on average, people had 17 years of injection experience. So even in experienced drug users, the blinding was not broken, and the treatment effects seemed to be preserved. So that led to our follow-up study, SALOME, study to assess longer-term opioid medication effectiveness. It asked the question, is perhaps hydromorphone as good as diacetylmorphine? In non-inferiority studies, there needs to be some ancillary advantage of the study drug, hydromorphone. The advantage of hydromorphone in North America and in Canada is just that it's a licensed analgesic. It doesn't have the same regulatory barrier or layers of stigma that diacetylmorphine may not deserve, but has. So we recruited folks who were at least 5 years using opioids, injecting opioids regularly, and they had to have had at least 2 treatment events, one of which had to be methadone or Suboxone, and as well as consequences of their opioid use. And using that criteria, the participants in SALOME were a little bit older. They had had on average 15 years of injection experience and had on average 11 attempts at treatment. So basically, we recruited folks that would be appropriate for this type of care and program. So just to add in a patient comment, this comes from Kirsten Marchand, who's done some work in patient-centered care in injectable opioid agonist treatment. And yes, we're providing a drug, and that's the key and absolutely essential. I'm not going to make any. Of course, we need to have that as the initial step, but it's an opportunity to add in other services and patient-centered services. This patient identified that what they liked about the medication was it stopped their need to do other things, not needing to go and buy street drugs, not having to go and do crime. Like I said, I always had charges. I was in and out of jail all the time. So this slide shows the primary outcome from SALOME. On the bottom axis here, we've got time in treatment, which is 6 months, and then number of days accessing street opioids in the prior month. So when people started in SALOME, basically they were accessing street opioids on every day. But by 6 months, that was down to a handful of days a month. And there was no difference between hydromorphone or diacetylmorphine. This is shows our sort of our average dose over time. So daily dose expressed in diacetylmorphine equivalent. Green is hydromorphone, blue is diacetylmorphine. And you can see that over the first few weeks, the dose increases as we're titrating. People are figuring out a dose that works for them, and then it kind of levels out. Also note that people actually take less than prescribed. This should be reassuring to folks that might be fearful that doses will escalate over time. That's not what we see clinically. And this sort of the Cochrane review suggested there might be some reduction in mortality. With our analysis from SALOME pooling data from NAOMI, Nick Bansbach, our health economist, has done modeling and a lifetime analysis model, and providing IOT, either diacetylmorphine or hydromorphine, in this population that continues to inject, rather than just continuing methadone, will result in 2 to 3 additional life years, or about 1 additional quality adjusted life year. So we can now say that adding IOT or injectable treatments onto somebody who continues to inject will reduce mortality. And we now have data showing that it also reduces societal costs, both for diacetylmorphine and hydromorphone. And on average, that's 140,000 in cost savings, Canadian dollars, over a patient's lifetimes. Most of that is attributable to savings in the criminal justice system and reduction in property and violent crime. And providing an injectable to somebody who's continued to use will, on average, reduce property crimes by 6. So somebody on methadone who's continued to inject 15 crimes per year, that reduces to 9. Just highlighting that this is a medical problem and manageable in the medical system. And it's much more efficient than trying to manage a medical problem in the criminal justice system. This is the reference if anybody would like to look it up in addiction. Nick Bansback, the lead author, and he shared these slides for me, so thank you, Nick. So the conclusion from SALOME, if you don't have access to diacetylmorphine, start with hydromorphone. And I think the DCHC folks and Dr. McDermid can, we'll be talking to how adding diacetylmorphine changed their programs. And in the broader context, the SALOME study and our participants showed evidence to support the supervised model that we have here at Crosstown. So supervised injectable opioid agonist treatment, safe, effective, cost-effective, reduces mortality, reduces crime. There's no controversy here, folks. I don't know why most said it was controversial at the beginning. I don't know. So just some words on Crosstown Clinic. We've been a program since 2014, initially with hydromorphone, and we had the first injection with diacetylmorphine, first treatment with prescription heroin in November of that year. Currently, we have 95 patients today who are attending for injectable opioid agonist treatment, 8 who are receiving hydromorphone, and 87 who receive diacetylmorphine. That's about 4,000 patient visits a month. And 70% of our patients take a sustained release opioid medication, mostly Cadian or Mesclon, some methadone, some hydromorphcontin, and we recently started using fentanyl transdermal patches, which are available to a limited extent now in British Columbia. We have 40 patients who are taking oral treatments and continue to be followed at the clinic. And of course, we don't do IOT in isolation. We prescribe and supply the full spectrum of treatments as well, whether that's risk mitigation and up to Sublocade for people who want to be on a depot option that allows them to come to the clinic even less frequently. 30% of our patients are Indigenous, and although people who identify as Indigenous have more health inequities when they start with us, within 6 months, all those inequities disappear. People who identify as Indigenous do just as well in care as everybody else. But 30% is an overrepresentation from the number of people who identify as Indigenous in the general population. So failure, in my opinion, to expand IOT is particularly problematic for people who identify Indigenous, because they are overrepresented in the illicit drug overdose deaths and are particularly at risk for harm. Gender, 70% of the patients at Crosstown identify as male and 20% as female. So predominantly male. And I think we need to review as a society how we offer care to people who identify as female. And I'm not sure if I was a young female coming into Crosstown, that walking into a space that's predominantly older men and mostly men would feel like a safe place. So how we design services for specific populations, I think we need to consider. The Crosstown team includes nurses, physicians, nurse practitioner, dietitian, social worker, clinic assistants, and social workers. So just back to the bigger picture. On Thursday, April 14th, 2016, over 5 years ago, we're now into the 6th year of an illicit drug overdose death crisis, a poisoning crisis in BC. And April was the worst month ever. 6 years into a public health emergency. But yet we do have prescription heroin now in Canada, and this is something to be optimistic about. I think there was no assumption and no guarantee that we would have an injectable treatment option when we started 20 years ago. And now there's clinics from coast to coast, from New Brunswick to British Columbia, including Alberta, Ontario, and Quebec in between. So that alone is reason for optimism. We can respond to the crisis with evidence. It's possible. So just to sum up, supervised injectable opioid agonist treatment, whether it's VAM or hydromorphine, will reduce mortality and are cost saving. It is a treatment option for those who continue to use street drugs with all the inherent risks, injecting related infections, and the risk of overdose and death. It substantially reduces people's need for street drugs, reduces crime, leads to more engagement with healthcare and allied services. And in jurisdictions where diacetylmorphine prescription heroin is not available, well, there are alternatives. And last slide here, this is Kelly Harper, our clinical coordinator. And I just want to highlight that it's our nurses that are doing the heavy lifting here and meeting our patients on a daily basis. And the clinic is just reopening now after lunch, and it's the nursing team that will be seeing our patients here. So a shout out to our professional colleagues and allies. So I'll advance the slides and pass on to the excellent team at DCHC.
Hello, I'm Karen Arnold, family doctor, and Barb McKillip, nurse practitioner, and I are going to briefly talk about how we were able to embed an IOT, which is injectable opioid agonist therapy program, into our primary healthcare clinic. We work in Vancouver at an integrated health center, and in Vancouver, we're located in the inner city, which is called the downtown east side. So Barb is going to present about our clinic itself, and I will just spend a couple of minutes talking about our injectable program. Next slide. However, first we would like to, and we want to acknowledge that we are gathering and working and living on the traditional, ancestral, and unceded territories of the Coast Salish people, which include the Musqueam, the Squamish, and the Tsleil-Waututh nations. Next slide.
Hi, I'm going to talk about who we are. The mission statement for our clinic is to provide compassionate, equitable, and integrated healthcare to those with the greatest need and least access to services. And that's what we're trying to do with our IOP program. We offer healthcare to the residents of the downtown east side of Vancouver, BC, that is low barrier, culturally safe, and trauma-informed. Most of these patients are living with complex health needs. Our multidisciplinary team consists of medical practitioners, psychiatrists, mental health nurses, RNs and LPNs, wound care clinicians, pharmacists and clinical pharmacists, a specialized HIV treatment team, a respiratory therapist, dietitian, and a podiatrist. We have social workers, counselors, financial workers, outreach teams, and peers with lived experience. We also have consultant physicians from internal med and infectious disease. So we have the full complement of an interdisciplinary healthcare team. We also have a specialty pain service and a tobacco dependence clinic. So DCHC serves approximately 1,400 patients. And our current estimate of patients with opioid use disorder is 673. We have offered oral opiate agonist therapy such as methadone at our clinic for decades. And now we are able to offer injectable diacetylmorphine and hydromorphone. Next slide, please. This is our main reception area at DCHC. And these are basically photos of our waiting room. Next slide. This is our primary care treatment area. And in our primary care, we have a lab a venipuncture area, and 13 private exam rooms, as well as an on-site pharmacy. Next slide.
Oh, that's me.
Okay.
So, yes, are you that you're done?
Yep.
Okay. In 2018, when the illicit drug supply became even more toxic and people were dying, our patients, we realized that we needed to offer some other options that didn't include the standard really low barrier options for oral opiate replacement that we had been doing for a while, because obviously it wasn't suiting a specific group of people. So with a huge amount of support and help from Dr. Scott MacDonald, Dr. McDermid, as well as Dr. Christy Sutherland from the BC Centre for Substance Use, we started our own IOT program within primary care. We started with hydromorphone because that was the only thing we were allowed to prescribe at the time. And with, again, a lot of support and help, we developed an induction protocol as well as maintenance protocols for injectable hydromorphone. And the program involves patients being able to come in once or twice a day. So it's a BID injection. Our clinic is open from 9 to 5, 7 days a week, 365 days a year. We're closed for lunch between 1 and 2. We have an excellent team that's very collaborative, including medical practitioners, very skilled, dedicated nursing staff, outreach staff. And I think what's also unique to our program is that we have a very involved group of pharmacists that have helped us a lot. And we've now also added a clinical pharmacist to our team. Our team meets once a week for an hour in addition to seeing patients, so that we can review current patients and we can go over protocols. We can change things quite quickly if things aren't working because we're a small program. And we also review new intakes. Our capacity for patients is 14 currently, and that's because of the space that we have and the time that we're open. In 2019, because I think our program was running quite smoothly, and also because the overdose crisis was not getting any better, we received some money from the Ministry of Health, which is our government, to expand our program to involve 50, which is 50, new patients. And we were starting that expansion, and unfortunately, COVID happened at the same time. So the funding, that project has been abandoned. I guess we're hoping at some point that in some way or iteration that could be revived. The most exciting thing that what has happened to our program recently is that with some regulatory changes in prescribing and really advocacy on behalf of our pharmacy team, we were able to start prescribing diacetylmorphine in March 2021. And this again involved a lot of support and help and development of guidelines by Dr. MacDonald. So when we were able to prescribe it, we offered all of our current hydromorphone patients whether they wanted to switch to diacetylmorphine. And I was thinking yesterday, I said 80%, but that's not true. 90% of our hydromorphone patients chose to switch to diacetylmorphine and maintain and continue on that to this day, which is a number of months still. And also of note, we have new inductions coming in quite regularly. And when we offer the choice for patients, whether they want to start and try hydromorphone or diacetylmorphine, 100% of them have chosen diacetylmorphine and have stayed on that medication. I think that's all I want to say for this. Next slide, thanks. And this one shows a picture of our IOT space with a bit of the patient journey. What happens is, if you see the right slide, the bottom right corner, a patient checks in at our front gate, goes to our IOT space, has a pre-dose assessment by the nurse. As long as that is fine, the nurse calls our pharmacy and the dose is ready for the patient. The patient then walks up where you can see on the left is a pharmacy pass-through window. They receive their syringe from the pharmacist and go to one of the 2 injecting booths. They do their own injections, or they can request help from nurses for intramuscular injections if they wish. Then they have a post-dose assessment. If the post-dose assessment is fine, then the patient can choose to connect with their primary care provider, connect with psychiatry, get wound care, see a social worker or a counselor, or they can choose to leave the clinic and go on with their day. Next slide, please.
Okay. Our IO program at DCHC has been a success in many ways for our patients. None of our folks who are IO participants have had any overdoses. Prior to this time, many of them did experience near fatal ODs on multiple occasions. Our participants have also had more engagement in regular health care. They are connecting with their medical practitioners, having their Hep C treated, adhering to their HIV treatment regimes, as well as engaging with psychiatry. Additionally, the patients have benefited from more social stability, such as better housing, no involvement with the criminal justice system, and connecting with their families. So we have found this prescribing of IO to be very rewarding for our practice, and we would encourage anyone who might be interested to contact us. Next slide.
So this is our chance to acknowledge that with an extreme amount of gratitude, Dr. MacDonald for his ongoing generous support with his time and expertise. We also do want to thank Fana Yee, who's our administrative assistant who prepared all of our slides. And finally, and of course, most importantly, we want to thank our patients who have been very patient while we continue to adapt and hopefully improve our program to make their journey a better one. Thank you very much.
Okay, hi, good afternoon, everyone. My name is Cheryl McDermid, and I'm a family doctor. I work at the Dr. Peters Center overseeing their IELTS program, and I also work at Providence Crosstown Clinic. Next slide. The Dr. Peters Center is located on the traditional, ancestral, and unceded territory of the Coast Salish peoples, including the Squamish, Tsleil-Waututh, and Musqueam nations. Next slide, please. Just before his death in 1992, Dr. Peter and his life partner, Andrew Hiscock, met in their home along with friends and Dr. Peter's sister, Nancy Hennessy. The decision was made to begin work on creating a place where people with AIDS could receive compassionate care right through to the end of their lives. That place is the Dr. Peters Center, located in the West End of Vancouver. Since 1997, the Dr. Peters Center has been providing care and support for people living with HIV and other health and social challenges. It was the first health center, our healthcare facility in North America, to integrate supervised consumption services into its model of care. In 2019, Health Canada paved the way for the Dr. Peters Center to launch a pilot project to create and provide a safe and legal drug supply for those with opioid use disorder and study how such a program works inside our holistic integrated healthcare setting. Next slide, please. The IELTS program allows individuals to receive prescribed hydromorphone or diamorphine as an injectable opioid treatment twice daily. The program started in 2019. We currently have 19 patients enrolled with 16 actively receiving IELTS. Our IELTS program is open to both HIV positive and negative individuals, and we have capacity for 20 individuals. Our syringes are dispensed to the center by a community pharmacy, Shoppers Drug Mart on Davie. Soon, we will be offering intranasal DAM and also take-home syringes. Next slide, please. IOT is one more tool in a campus of care model at the Dr. Peter Center. Prior to COVID, approximately 180 individuals attended the Dr. Peter Center daily, partaking in many of the services and programs offered. The Dr. Peter Center serves 73,500 nutrient-dense meals to participants and residents every year. The center provides individual and group counseling in a caring and judgment-free space. Other supports include a 24-bed licensed care facility, which includes long stay, stabilization stay, and end-of-life care. The Day Health program supports people in improving their health, which can include nursing care, administering prescribed medications, including HIV meds, hepatitis C meds, oral OAT, and IOT. There is art and music therapy, weekly activities, outings, and computer literacy programs. The Dr. Peter Center also offers enhanced supportive housing, which includes 9 fully supported suites and 4 partially supported suites. Next slide, please. This is a photo of our IOT room at the Dr. Peter Center. Pre-COVID, we could have up to 6 participants at any one time. During COVID, only 2 participants used the room at any one time. Next slide, please. I would like to thank Patrick McDougall for putting these slides together for me. And I would also like to acknowledge and thank the staff and patients of the IOT program at the Dr. Peter Center. Thank you. I think we're open for questions.